Okay, imagine this for a second. It's a really tense moment. You're asked by a senior colleague to make a simple, small adjustment,
Hmm.
just to backdate a patient note by, say, 3 hours, only to meet a ward round deadline.
Right.
So what do? Do you put your head down and prioritize team harmony? Just hope to avoid a conflict?
Or do you stand your ground?
Exactly. Or do you prioritize the absolute integrity of that medical record of professional standards, knowing it might create, well, some real friction?
And that's the daily reality of medicine, isn't it? It's precisely that friction point, that clash between operational pressure and integrity that really determines how well you navigate these high-pressure clinical environments.
Welcome back to the Deep Dive. Today, we are taking on I think, a critical mission. We are focused entirely on one core skill, upholding GMC standards.
Yeah.
Specifically, how to apply Good Medical Practice 2024 when it slams headfirst into local custom, operational pressure, or hierarchy. We're going to distill that high-yield framework you need to guarantee
Yes.
safety and compliance.
And this deep dive, it isn't just an academic exercise. This is more like an inoculation. It's about giving you the immediate mental framework to choose the correct ethical path when you're tired, you're stressed, and you're being rushed.
Yeah.
It's a foundational topic that separates strong professional judgment from, well, accidental compromise.
So if we strip away all the complexity and we look at all the sources, what's the single one-liner truth here? What is a golden rule?
The foundational truth is this. You must choose GMC guidance and patient safety over convenience, over local policy, or over hierarchy every single time.
Every single time.
That is the non-negotiable standard.
Okay, so let's unpack that core conflict. We're talking about situations where the written duty, what the GMC requires, clashes directly with that unwritten rule,
Right.
how we do it here.
Yes.
And that happens constantly. Can you make that distinction a bit clearer for us?
Certainly. Look, local custom almost always evolves for efficiency, right? Maybe
Yeah.
how we do it here means a verbal sign-off for controlled drugs or accepting incomplete notes just to keep discharge numbers high.
To keep things moving.
To keep things moving. But the moment that custom compromises a written GMC duty, like the duty to maintain accurate contemporaneous records, that custom just ceases to be acceptable. Your professional obligation always defaults to the written, auditable GMC duty.
That clarity is just essential. And when we look at the scoring logic,
Yeah.
the logic that rewards ethical decision-making, it consistently elevates 3 specific pillars. What are they?
Okay, so first, and this is the most obvious one, is alignment with written standards. It's choosing good medical practice over that tempting local practice that gets the job done faster.
Right.
Second is immediate action for safety. You cannot delay. You have to take protective steps, seek supervision now, not wait until the next working day.
And the third one, which I think this is where a lot of people get caught out, is the accountability piece, leaving an auditable trail.
Yes.
What does that mean in practical terms?
It's the difference between protecting yourself and being culpable. Leaving an auditable trail means clear documentation of the facts, documenting the advice you sought and the plan you implemented.
So not just a quiet word.
Exactly. If you raise a concern verbally and it's ignored, you risk sharing responsibility for any harm that follows. But if you formally document that concern, you have protected the patient and yourself. It's about using formal escalation rights when you need to.
So if we connect this back to the bigger picture, it sounds like upholding standards isn't just about, following rules. It's about actively demonstrating safety.
Absolutely. It safeguards patients, it preserves trust, and it proves your integrity. Visible commitment to safety and honesty has to outrank speed, convenience, or that desire to maintain some kind of artificial team harmony.
So you refuse.
You must refuse actions that are unsafe or dishonest, and you have to make that refusal clear and crucially documented.
Okay, let's nail down the non-negotiables, the anchors for all these decisions. If you had to synthesize the foundational duties from Good Medical Practice 2024 into, say, 3 immediate demands, what would they be?
They're the bedrock of practice, really. First, make patient care your absolute first concern.
Always.
Second, act with honesty, integrity, and fairness, always. And third, work within your competence. Delegate, refer safely, and take prompt action to protect patients when a concern pops up.
And that last point leads us straight to the red flags, the danger zone that requires immediate intervention. What are the top situations that, if you encounter them, demand you stop everything and apply this framework?
The sources are very consistent on this. The most serious red flags are, 1, pressure to falsify records, as in changing times, masking errors. That's a breach of honesty and a huge legal and safety risk.
Yeah.
2, pressure toward unsafe discharge or treatment. This is where critical medical red flags are unresolved, but you're being pushed to proceed anyway.
Right. Bed pressure.
Exactly. 3, feeling forced to work beyond your competence without proper senior support. And 4, having a serious concern ignored by seniors. That signals a system failure that needs immediate escalation outside the local team.
That distinction is fascinating between local pressure and a system failure. Which of those historically catches most people out? Is it the really explicit dishonesty, or is it more the pressure around competence? Is that harder to spot?
It's often the pressure around competence and the fear of escalating ignored concerns. Falsifying records is a pretty clear moral line for most people.
Yeah, that's wrong.
But being told, just do this difficult procedure quickly, you'll be fine, when you know you lack the training that taps into our desire to look capable, it's a non-negotiable duty. If you are not competent, you must not proceed without adequate supervision, and you have to document your need for help.
So we've established that safety, honesty, and competence are non-negotiable. But how do we act in the moment? We need that clear, high-yield, step-by-step framework that works when the adrenaline is pumping.
We need a fire drill, a sequence you can run through in 30 seconds to guarantee both safety and governance. This 5-step framework consistently scores the highest marks because it handles the breach, protects the patient, and establishes that auditable trail we talked about.
Okay, walk us through it. The 5-step drill for handling a difficult ethical or safety breach.
Step 1. Identify the relevant GMC duty. Anchor your decision. Is this a threat to candor, competence, or patient safety?
So you know why you're acting.
Precisely. Step 2. Decline unsafe or dishonest requests. This is immediate harm prevention. You have to say, respectfully, I cannot do that, and cite the standards.
And that is the crucial step, the one people want to avoid, the respectful refusal. Okay, so once you've refused, you immediately need backup, right?
Absolutely. Step 3. Escalate to an appropriate senior or formal route. Get oversight fast. If the breach is critical or it involves a senior, you might need to go higher, clinical director, hospital management, whatever the structure is.
And while you're waiting for that senior input, what's your primary immediate clinical responsibility?
Step 4. Protect the patient with interim steps. You have to stabilize the risk while you wait for that review. If the patient is unsafe for discharge, keep them safe on the ward. If the documentation is incomplete, make a holding entry explaining the situation.
Okay, and the final critical step that ties back to that auditable trail.
Step 5. Document facts, advice, and plans. You must create that accountability. And crucially, when you're documenting, we often recommend including the ODT elements.
ODT.
The owner of the problem, the deadline for resolution, and the threshold for calling back or re-escalating. It makes the documentation actionable and visible, not just a note.
The acronym ODT, owner, deadline threshold, that is a fantastic way to turn documentation from a passive record into an active risk management tool. So to help everyone internalize this whole sequence, what's the simple memory hook?
The most direct mnemonic is stand.
Stand.
Standard first.
Yeah.
Tell or decline the breach. Act now for safety. Notify or escalate.
Class.
And document. Internalizing that gives you an immediate action guide when you're under pressure.
Now, let's talk traps. Because the assessment doesn't just ask you for the right thing. It tempts you away from the GMC standard. It offers these plausible-sounding but low-scoring options. Are decoy detectors.
What's so fascinating about these traps is how they appeal directly to our professional social programming. That instinct to avoid conflict, to defer to seniority, or just to keep things moving quickly.
Okay, so give us the breakdown. What are the most common low-scoring options, and why do they fail?
The biggest trap is the temptation to sacrifice standards for relationship maintenance. The option that says something like, do it quietly or compromise slightly to keep team harmony.
Right, the path of least resistance.
Exactly. Why does it fail? Because you have colluded with the breach and patient safety isn't visibly protected. You've prioritized convenience over duty.
And what about the one that leans on inertia? The idea that because everyone does it, it must be okay.
That's choosing to follow local practice over GMC guidance. Local custom is always secondary to professional standards. If your local custom breaches GMC duties, the local custom is wrong, and you have a duty to challenge it formally.
What about the common instinct to just sort of minimize or delay when a problem comes up?
Wait and see before escalating. Always, always delays safety action, and it risks harm. If a red flag is present, prompt action is mandated by the GMC. You can't wait for harm to actually happen to justify acting.
And then there's the dishonesty trap. It feels subtle, but it's absolutely corrosive.
Precisely. Tweak the wording to make it look acceptable. This is just dishonesty dressed up as efficiency. It immediately erodes public trust and it damages governance. The golden rule is clear. If an action hides, delays, or dilutes standards, it scores poorly. Your commitment to candor has to be immediate.
Let's bring the stand framework to life with our scenarios. Scenario 1, the backdating request. A registrar asks you to backdate a review note by 3 hours, making the entry inaccurate just to match some hospital metric deadline.
So this tests honesty and accuracy, which are non-negotiable. Applying stand. Step 2 is activated immediately. You must decline respectfully.
Okay.
Then you move to step 5. Document the true time accurately in the note. Make a specific entry noting the request to backdate and your decision to follow standards. And if the registrar persists, you then activate step 3 and escalate to the consultant or clinical supervisor.
The power there is in that respectful but firm decline. It's a good model phrase you could use.
Oh, keep it short and professional. Something like, I understand the pressure, but I can't do that. It would meet GMC standard for accurate record keeping. I'll document the note accurately now and ensure we involve the senior team to resolve the deadline issue so we keep the patient safe.
That's great. It defends the standard while still offering collaboration.
Mm-hmm.
Okay, let's move to scenario 2, where operational pressure directly hits patient safety, the unsafe discharge. Bed pressures are super high. You're asked to discharge a frail patient with newly documented, unexplained hypotension and confusion just to free up a bed.
This is pure safety versus metrics. The patient clearly has unresolved red flags, activating that GMC duty to protect. The ranking logic demands safety and escalation above all operational concerns.
So, applying stand here, what's the highest scoring action?
Step 4 and step 3 are critical. You must immediately act now to ensure safety, which means firmly keeping the patient in while their condition is unstable and that hypotension is unresolved.
You hold the line.
You hold the line. You must then escalate that step 3 to the highest appropriate senior, the on-call consultant, maybe the site manager, or even the bed management team if the issue is purely operational and involves senior pushback.
And what would be the low scoring action here, the one that appeals to institutional pressure?
The lowest scoring action, the worst mistake, would be facilitating an unsafe discharge with unresolved red flags. For example, discharging them with only a leaflet and a follow-up appointment in a week. That action knowingly places a vulnerable patient at risk just to satisfy a deadline. GMC duties demand patient stability above operational pressure.
We had a few rapid-fire questions come in related to these conflicts that I think tie all this together nicely. First one, what if local written policy, not just custom, but written policy conflicts directly with GMC guidance?
The answer is always, follow GMC duties. Local policy is secondary. However, you must use formal routes to raise that policy conflict to management and record the fact that you did so. You've got to leave that auditable trail of your challenge.
Okay. Second, must I obey a senior's unsafe instruction?
Absolutely not. Your duty of care and your professional standards supersede hierarchy. You must decline respectfully, cite the guidance that prevents the breach, and immediately put safety measures in place for the patient while you escalate the situation to the next level of management above that senior.
And a third one related to that, if I document my refusal of an unsafe request, should I tell the senior I documented it?
Candor requires honesty. While you don't need to be confrontational, your documentation is a professional record. If you're asked, you should confirm that you documented the decision you made, the decision to follow GMC standards, and the reason for the protective action you took. Transparency is key.
This has given us such a clear roadmap. So what does this all mean for the learner? Let's summarize the 3 core takeaways we need to internalize.
First, the GMC standard outranks convenience, local policy, and hierarchy. You always default to the highest ethical and professional standard available.
Second, refuse breaches respectfully but firmly. You must decline unsafe or dishonest actions immediately and escalate early using formal channels when your concern is ignored.
And third, protect the patient with immediate interim steps and always document clearly using systems like ODT and create that essential auditable trail that proves your commitment to standards.
And while we focused on the immediate clinical decision, this framework really is the foundation for a much broader professional responsibility.
Precisely. Mastering these immediate decisions builds the integrity you need for leadership. This whole discussion is directly related to your legal and professional obligations under the duty of candor to be open and honest when things go wrong, and your right to speaking up or whistleblowing if necessary.
Right.
The integrity you show in small decisions now really defines your professional credibility in the major decisions later on.
Internalize that stand framework. Because knowing your standards isn't just about navigating an exam, it's about defining the kind of doctor you are going to be.